Hello, my name's Lisa Mann. I'm a physician assistant at Park Royal Hospital. I work with all sorts of patients. I work with your geriatrics, your dual diagnosis, so addiction history, depression, anxiety, bipolar, OCD, schizophrenia, schizoaffective, basically anything you can think of. The one field I don't really work very much in is with children. So a lot of the topics we're covering today really don't have much to do with children. It's more about mental health self-care in demanding roles like people who are teachers, law enforcement, medical professionals, administration professionals, just all sorts of people, and all the diagnoses that can affect these people. So we're going to start with an overview of mental health, just basically all the major diagnoses that can affect people in demanding roles and the treatments available for these diagnoses. Now, there are more that I could have included, but I had to put a limit somewhere, right? Because I could talk about this forever. So I really just included depression and anxiety, which are really the most common. Bipolar disorder, I wanted to include because a lot of people don't realize that high functioning, very successful people, specifically people in sales or marketing or just fields where you have to be very charismatic and outgoing, are often bipolar and actually hypomanic. And it just is written off as like, oh, they're very charismatic and upbeat and high energy. Obsessive compulsive disorder, you'll see, this exists on a scale. So everybody thinks of like Monk in the TV show and like he's really, really OCD, but actually, a lot of people have this to a smaller degree and they still function successfully with it. Psychotic symptoms, you would see this less so, but it's still something that I want to address just because people think, oh, it's only in the realm of like schizophrenia, but no, it's actually something that affects multiple diagnoses. We're also going to talk about substance abuse and addiction because in demanding roles, people very often turn to substances as a form of self-medication. And especially if they're very disciplined and organized, they think, well, I can just medicate myself a little bit, and then it starts to get out of hand over time. So alcohol abuse, controlled substance abuse, that would be your opioids, your benzos, your sleep medications, even stimulants like Adderall, Vyvanse. There are other addictions. I didn't cover these very much because it's just something that more is addressed in CBT therapy, so I would refer out for a lot of these, but gambling, hoarding, pornography addiction, these are all things that high-functioning people can suffer with. Lastly, I included a bit about self-care just to prevent burnout, to keep your motivation going, relationships, just making sure that your demanding role doesn't burn out all your relationships and cause you a bunch of problems. Depression is something that most people will encounter at some point in their life, whether it's after the death of a loved one or just in a phase in their life where things are not going so great. Depression's been huge during the pandemic because humans are very social creatures, so to avoid all these get-togethers and things that we look forward to has been very hard on everybody, I think. Except for the few introverts who are just absolutely ecstatic, which lucky them, right? So the demographics of depression, it's estimated to affect somewhere between 3.7 to 6.7% of the population. Now, I would guess that this is an underestimate because so many people just don't, whether it's culturally or because of their position or because of just anxiety, do not come forward and receive treatment for this. I think a lot of people hide it very well, which is how, you have those suicides that are completely unexpected. The person was like captain of the football team or something very prominent, and then they seemed happy and social and fine, and then passed away due to suicide. Well, they probably had depression that just never got diagnosed or treated or even spoken about, and there's many reasons why somebody wouldn't come forward with that, but our goal really in psychiatry is to make sure we get everybody involved, everyone getting treatment, especially those people that are hesitant to, because I think they need it sometimes the most. So depression is thought to be a combination of genetic and environmental factors. And the way I like to explain this to my patients is you had a genetic predisposition to this, and an environmental factor like death of a loved one or loss of a job or just whatever happened brought this out at the time that it started becoming a problem in your life. So genetics are estimated to be about 40% of the risk. It is 2 to 3 times more common in adolescent and adult females than males of the same age. And the most affected group with depression is age 25 to 44. So your young to middle-aged adults in the workforce, which is a lot of us and a lot of people just kind of keeping that to themselves and not really discussing it. So depression has a lot of neuroendocrine factors. People don't realize how much depression is really a medical thing, but there's a lot of data to show that your body, like your neurotransmitters, your hormones, are not reacting the way that it's supposed to. So two of the major axis we're going to talk about here, HPA, hypothalamic pituitary adrenal axis, and hypothalamic pituitary thyroid, so your HPT. These are both associated with depression and anxiety. With your HPA, you'll find that people with depression have increased adrenocorticotropin secretion, ACTH. That's the precursor to your cortisol, your stress hormone. So these people are in that fight or flight more often than the average person, and that can lead to fatigue, exhaustion, depression, and a lot of the poor concentration you see with anxiety. With the administration of anti-glucocorticoid medications in these patients, so stuff to antagonize that cortisol release to prevent it from happening, they notice an antidepressant effect, which is, I think, really interesting, something that not a lot of people know about. The HPT, there's an association between people who are diagnosed with hypothyroidism and people diagnosed with depression. There's a lot of overlap. Depressed patients tend to have lower T4, so that's that end product, that's the end of that axis. They found improvement in depression symptoms with the administration of thyroid-releasing hormone, which is really interesting because basically by kickstarting that axis, by giving it a little push, there's less depressive symptoms. Subclinical thyroid dysfunction has been noted in depression patients, so this is people that their labs may come out fine, but when you really look at the thyroid, it's not working exactly the same way as the average person. Depression has a lot of symptoms, and of course everyone thinks of, well, depressed mood, crying spells, guilt, poor self-esteem. Something people don't know about as much is sleep disturbances, either sleeping too much or too little. Either can be related to depression. Increased or decreased appetite, so overeating, called emotional eating, when you're trying to deal with the way you feel by consuming food that feels good, comfort food over and over, and this can actually lead to a cycle of guilt related to that overeating, causing more overeating. Decreased appetite, sometimes when people are so depressed or in that fight or flight state for so long, they just do not have an appetite anymore. Poor motivation is when people just can't bring themselves to get out of bed. They don't feel like doing much of anything, all the things they used to do, hobbies and stuff. It just takes too much effort. The lack of enjoyment when you do actually, so say you do get the motivation to do these hobbies, if you do them and you find you're not enjoying yourself and you just don't get why anybody would do this, that's called anhedonia. So watching TV and not getting the joy you used to, riding your bike, things like that. Irritability. People think anybody who's irritable is just automatically a mean person or, a jerk. But a lot of times when you're just really down and you're constantly, chronically depressed, it takes a toll and you're just tired and cranky and you just can't really cope with social interaction. So you become very quick to snap. So irritability is something that, people are responsible for the way they behave, absolutely, but it should be recognized as a symptom of depression. So there's a huge stigma about getting treatment for depression, and it's really, for me, one of the things that I'm very passionate about speaking against is people should not be afraid to get help. I think being afraid to get help just causes more negative outcomes for your patients, for your clients, for whoever you're working with, because you can't provide your best service if you're not taking care of yourself. So the problem is a lot of applications for major careers have this line that I hate, which is, have you ever been diagnosed with a psychiatric condition such as, and they'll include depression, anxiety, and of course everyone has been depressed or anxious at some point. Don't encourage people to lie about that. I understand they're trying to weed out people who have something that would impair their ability to function, like a condition that would make them unsafe for that role. But I think in reality, how many impaired schizophrenics do you have applying to be, doctors and lawyers versus how many anxious and depressed people you're scaring out of admitting? I think it just does more harm than good, but I understand where the question comes from. So, like I said, this is detrimental because most psychiatric conditions, they impair concentration and memory. So you're not giving your best care. Like when you're depressed and when you're anxious, you're more likely, in my opinion, to make a med error. You're more likely to forget something. You're more likely to omit something. And I think that getting people on medications or getting therapy will make people better providers and better professionals in general. So here's a study that's kind of a downer. A new poll of emergency physicians on the front lines of the COVID-19 pandemic shows many are concerned about seeking mental health care for fear of stigma and potential negative effects on their career. So we've got these people who are working in a very difficult situation, dealing with a lot of very sick people, living in constant fear about getting sick, bringing that sickness home to their family. Long hours, heavy PPE, lots of different opinions on the pandemic floating about. And it's just natural to feel stressed in that situation. And it's very depressing that these people cannot seek help out of fear that they may be seen as unstable and, not fit for their job. When really you'd have to be kind of a bit of a sociopath not to be affected by this. So I think being depressed and anxious in response to a situation like this is very normal. So the treatment options, if you do suffer from depression, antidepressant medications, we've got quite a few classes. SSRIs are the most common, so that's your Prozac, your Lexapro, your Zoloft, Paxil, Celexa, Luvox, Vibrid. These are the ones that I would consider first line. That's what I would start somebody on. Of course, there's other reasons to start somebody on something else. If they have, say, pain, Cymbalta will help with pain. So in that case, you would start with an SNRI. But usually you start with an SSRI for somebody with no medical history, no issues, first time they're getting treatment. And SSRI is a good choice. SNRI, like I said, they help with pain. Effexor is found to be very helpful for the treatment of PTSD. You also have Wellbutrin, Wellbutrin SR. These are ones that are very good for people with addiction history. These are good for people who want to stop smoking. It is bad if anybody's ever had seizures. They should not be taking Wellbutrin because it does lower your seizure threshold. TCAs, these are a bit older medications. We don't see these as much anymore, though they are used for sleep sometimes. Elavil, Anafranil, Doxepin, and Tofranil. If you are on the max dose of an antidepressant and it was working, but it's not really working so much anymore, something really great you can do rather than just come off it and start all over with a new one and have to wait for that one to build up is to just augment it. And you augment it with an antipsychotic. So that's your Abilify, your Vraylar, Seroquel, Risperdal, Zyprexa. And then you can also add in Wellbutrin. Now, Wellbutrin works fine on its own as an antidepressant, but you can use it in combination with your SSRI or your SNRI and give it a little bit more push. So outside of the medication management we just talked about, there's ECT, electroconvulsive therapy. Now this one is sometimes a very hard sell for patients because it sounds very scary. It sounds very old school, like, strap you down to a table and shock you. But it's actually a lot different than it used to be, and the advancements in it have it very quick and straightforward and non-invasive. So patients are sedated. Between 70 to 120 volts are applied just to the brain externally. And this causes controlled seizures in the brains. This kind of just causes enough damage or trauma to shake things up to get these neurotransmitters, these synapses working again. Whereas before, medications were just kind of being applied to atrophied pathways. This is getting them kind of refreshed and damaged so that they regrow and become more susceptible to medications. This is indicated in depression, in mania, in schizophrenia, and catatonic presentation, so that can come from depression or schizophrenia. Something cool about ECT, it can be used in pregnant women. About half of the people who respond to ECT will require some additional treatments within a year of having it. Some adverse effects of it that people report is confusion and maybe some memory loss. Talking with patients, for the most part, they feel that it was worth it. I do occasionally have one or two people who are like, my memory's not so great, I don't feel like it was worth it. But for the most part, I do encourage my patients to try it because a lot of times when you're dealing with crippling depression, you'll take a little bit of memory loss to not feel that way. ECT is given 2 to 3 times a week, and there's usually about 12 treatments in the beginning, but that's really up to the discretion of the doctor doing it. Sometimes they'll feel that you need more. Transcranial magnetic stimulation, TMS, that is when a magnetic field is used to cause a current to pass through a specific area of the brain. This is also non-invasive. This is mostly used for depression. It can also be used for migraines. The adverse effects of it are actually very rare. Most people tolerate it really well, but you can have fainting, seizures, cognitive changes, or discomfort after the procedure. Ketamine is a new and very hot topic for depression. It was actually approved so recently. It was in March 2019 that it got approved for the US. It's used typically as an anesthetic, so that gives you your sedation, memory loss, and pain relief for surgeries, procedures. When it's used for depression, they give a sub-anesthetic dose, so not enough to make you unconscious, but enough for you to feel effects of it. Unlike antidepressants, this actually works within 4 hours. Antidepressants take about a month for the full effect. And the effects of this can persist for weeks after an infusion. So you do have to do it as maintenance. You do have to keep coming back for it. Esketamine, which is the enantiomer, the molecular mirror of ketamine, is what was approved in the US. It's given as a nasal spray. Generalized anxiety disorder. Anxiety is a normal experience. Everybody gets nervous. Everybody, if they're doing like public speaking, or if they're waiting for test results, if they're about to get bad news, everyone gets their heart racing, chest pain type symptoms. But generalized anxiety disorder is when this is excessive. Your anxiety is irrational, like there's no basis for it. Uncontrollable worrying, you can't just stop, you can't just move on from it, and it gets to the point that it interferes with your ability to function in daily life. Now, symptoms persist for 6 or more months before it's formally diagnosed as generalized anxiety disorder, because some people just do have like stressful periods in their life. Like when I was in physician assistant program, I don't think I was doing well in terms of anxiety. I was very nervous, tests every day, constantly studying, but that's not enough to be diagnosed as generalized anxiety disorder, because that has a cause, it's not irrational worrying. It's very normal to worry about exams, right? So this would be irrational without a basis worrying for 6 or more months. Generalized anxiety disorder should be differentiated from panic disorder. Panic disorder is when you have specific events of anxiety, like panic attacks, where you're doing something and you have to leave the room because you can't breathe, because you feel numb, because you're dizzy, lightheaded, maybe even about to vomit. Generalized anxiety disorder is more of a slow burn anxiety. It's more like you're constantly like, well, what if I crashed my car? What if? And you're just always thinking like that. Panic disorder is where you're mostly doing okay, and then you start to have these panic attacks where you cannot function in that moment. However, treatment is similar for both of those. We're going to talk about that in a second. Demographics, the risk of developing generalized anxiety disorder has been estimated at 9%. It's been diagnosed in approximately 3.1% of the US population in age 18 or older, which is 9.5 million people. So that's a lot of anxious people. It is 2 to 3 times more common in women than it is in men, and there is an increased risk of developing this disorder after experiencing a traumatic event. So for example, one thing you hear a lot is like, people will tell me, I was fine until I got sexually assaulted, or I was fine until I was in a very bad car accident, and after that I just started to feel anxious and nervous all the time. And that's really like you are responding to that event in a way that your brain is just stuck in that fight or flight anxiety mode. So there's a lot of symptoms of anxiety. It can be very different from person to person. Restlessness, fatigue, trouble concentrating. So a lot of people who can't get off their cell phone and are always fidgeting with their phone, that can be anxiety. Irritability, feeling tense, difficulty sleeping, heart palpitations. So I put heart palpitations twice. Sweating, trembling, shaking, dry mouth not attributed to medication. Difficulty breathing, so like hyperventilation, or feeling like no matter how much you breathe, you can't get a deep enough breath. Choking sensation, chest pain. The interesting thing about chest pain is I personally know several people who are very, you would think the kind of person who presents to the emergency room with an anxiety attack is over dramatic, or maybe not you, but some people would think that. And actually, I know people who presented to the emergency room thinking they were having a heart attack, people who are very reasonable, very non-dramatic, very straightforward people, and it ended up being diagnosed as anxiety, because anxiety is such a strong physiological experience. You can actually feel like you're having a heart attack. So it's not just something to be written off as like, oh, well, they're just dramatic. It can be a very scary physiological experience. So dizziness, nausea, depersonalization, which is that kind of dissociative, like feeling like you're not connected to your body and you're kind of watching as like a third person observer. Hot flashes or cold chills, that feeling if you like can't find your wallet for a second, or if you almost rear end somebody, it's that kind of feeling of just your blood runs cold. Numbness or tingling or a lump in your throat sensation, feeling like when you swallow there's just something there. The treatment for anxiety, there's a lot of different approaches here. Cognitive behavioral therapy, that's where you work with a therapist to understand why you're anxious and what you can do to kind of interrupt that pathway. You can do exposure strategies, which is where you are associating with this stressor on your terms, little by little, till you're comfortable with it. It can be used alone or in conjunction with medication. And I don't believe I mentioned this for depression, but depression also can be treated with CBT. So depression can be done with medication in combination with CBT or with CBT alone. However, typically SSRIs and SNRIs are the most effective. Treatment for anxiety, you want to use an antidepressant. A lot of patients immediately just want benzodiazepines and they don't want to take anything else. The problem with that is, and I explain this daily, a benzodiazepine is a Band-Aid. So you are having a panic attack, you take the benzo, and the panic attack goes away. But we don't want you to have to stop your day, dig through your purse or your bag, take a pill, and then get back to work. We want you to never have felt that way to begin with. And that's what the SSRIs and the SNRIs really do, is they work on that pathway, the depression anxiety mechanism. They tone it down to the point where you're not having those panic attacks. Now, I like to use benzodiazepines with people who do not have addiction history because they're very addictive, in very, very small amounts as a bridge while they're getting used to their antidepressant, while they're waiting for it to build up in their system, maybe 5 or 6 pills a month for those really rough days. But the goal in the end is to not be on benzodiazepines long term, because they just stop being effective, and then you need them to not go through withdrawal, and they're also not even working for you because you've developed a tolerance. So benzodiazepines, I'm a big fan. I like to use them, but very sparingly and preferably not daily. Now, sometimes I do have patients that come in and they've been on Klonopin since like the 70s, and it's like, well, I'm not going to taper them off of it for them to only probably go back on it, but I wouldn't have started them on it, is what I'm saying. There's a huge risk of developing a tolerance, becoming dependent on it, becoming addicted to it, and abusing it. Neurontin or Lyrica, those are good medications for anxiety. They also are very helpful with people that have fibromyalgia or chronic pain, nerve pain, diabetes, induced neuropathy, and those are not addictive, though there is some instances of people abusing them. Typically, they're not considered addictive. Vistaril is a great option. It's an antihistamine that also works on serotonin. So it's very different from your Benadryl, where this is more of a sedating, calming medication. However, the biggest complaint with this one is people say that it does make them feel sleepy. So bipolar disorder is something that we talked about earlier, is very common, especially in people who are very successful, charismatic, high energy. A lot of those people that are always working and don't seem to need sleep. A possible cause of that is they are bipolar. So this is characterized by periods of very high energy, elevated mood, followed by periods of low energy and depression. Typically when I screen for this, I ask patients, do you have periods of like, I can do everything, I don't need sleep, I have a million goals, I'm going to accomplish them all, followed by a crash into where they're just remaining in bed, they don't feel like doing anything, they can't work up the energy to get out of bed, that sort of thing. Elevated mood can be mania. That's when it's associated with psychotic symptoms. So confusion, disorientation, sometimes even hallucinations, just when people are not in their right state of mind. Hypomania is more when they are in their right state of mind, but they have these symptoms of pressured speech, flight of ideas, their concentration is just very poor, they can't focus. Grandiosity, that's when they're like, well, I'm very intelligent, I'm very smart, I'm very accomplished, and it's really that mania that's making them feel like they are the best person that ever existed. A lot of people will see that without context and be like, wow, they're kind of like full of themselves, but it's actually a symptom of this condition. Bipolar classifications, these used to be discussed a lot. Now they've kind of fallen out of favor, and we talk about bipolar as in most recent episode depressed or mixed or manic. But bipolar 1 is when they've had a manic episode, like a severe manic impairment. Bipolar 2 is when they've only had hypomanic episodes and no full manic episode has been ever recorded. Demographics. So bipolar disorder is estimated to affect 1% of the global population and 3% of the US population. So think about that. That's like if you know 100 people, like 3 of them have some degree of bipolar disorder. Genetic factors account for 70 to 90% of the risk, so obviously this is a lot higher than we were talking about before with our depression, anxiety patients. This is something where you really want to screen for family history because that is a huge part of it. Rates are equal in males and females, so either males or females have an equal risk of getting this. I'm very skeptical when somebody comes in and says they are developing bipolar at around age 60 or 50 because the onset usually is around early 20s. It's very rare to see it develop later in life. Earlier onset is associated with a worse prognosis, so when you see people start showing symptoms at like 17, 18, as opposed to like 25, that's considered a worse prognosis. Death from natural causes, so nothing to do with the bipolar disorder, but just death from like a car accident or a heart attack or anything else like that, is twice as high compared with the general population. This is assumed to be because people with bipolar disorder make more risky life decisions, like doing recreational drugs, risky sexual encounters without protection. So that's higher risk of your car accidents, your STDs, your HIV, drug-related deaths. Also, lifetime suicide risk is very high, 6% complete suicide in a 20-year period, which sounds like a small amount, but when you think of the amount of people that are bipolar and you think of 6% of those people, that's quite a lot. Symptoms of bipolar disorder, the manic, hypomanic episodes like we talked about with crashes into depressive episodes, impulsive behavior, so excessive spending, hypersexual behavior, so staying with a bunch of different people overnight and not knowing them very well and not using protection when the person is usually not behaving like that. Like, not to come from any place of judgment, but that this is out of character for them. Risk-taking behaviors, so people who are like running red lights just to feel alive, that sort of thing, that's very characteristic of bipolar disorder. Decreased need for sleep. One of the things I think of when a patient tells me, oh, I don't really need much sleep, I'm thinking, well, are you bipolar? Because bipolar patients, they don't sleep a lot, and the lack of sleep seems to precipitate the mania. Then the mania gives you more lack of sleep, so it really does seem to be related. Hallucinations. So this is more your bipolar type 1, but seeing and hearing things can occur with bipolar disorder. Disorientation and confusion. Not being oriented to time, person, or place can happen with severe manic episodes. Hyperverbal or pressured speech. These patients sometimes don't let you get a word in. They're just talking. They're talking over you. They're talking very fast. It sounds like their mouth can't keep up with how fast their brain is moving. So euphoric mood, people who are just very happy, overly energetic, just thrilled, disproportionately thrilled to be in the situation they're in. Like, some people come into the psychiatric hospital and they're just like, I love you and you're great and blah, blah. And I'm like, thank you, but that is not a normal thing to feel to somebody you just met, and you're involuntarily committed to a place you didn't plan to be at. So your response to this situation is not considered appropriate. As much as I do love to see them that happy, it's not for good reasons. It's due to their illness. Treatment for bipolar disorder, most commonly you do use both a mood stabilizer and an antipsychotic. However, you can do just one or the other depending on the symptoms. Lithium, Depakote, Lamictal, Tegretol, these are all things that prevent mood swings, that just keep you from, you don't want to have anybody feeling numb or flat, or like people say, oh, the meds make you like a zombie. That's not the goal. It's just to kind of take that range of emotion and just bring it in a little bit to a more appropriate range. Antipsychotics, you have your typicals and your atypicals. So your typicals are your old school ones. Those are your Haldol, your Prolixin, your Trilofan. The downside of those is that you will get more EPS, so you more like tremors, muscle rigidity, tension. With your atypicals, metabolic effects like high blood sugar, weight gain, diabetes, lipids being high. So those medications, Seroquel, Zyprexa, Risperdal, I do really like them because they don't have those nasty side effects of EPS, but you do want to be doing regular labs to make sure that the patient does not have any symptoms of metabolic effects. Obsessive compulsive disorder. So this is something you'll see in your high functioning professionals a lot, right? Because a lot of what makes them super organized and super together is actually driven by an underlying anxiety problem. And I think there's so many people that you talk to, and the more you get to know them, like you realize that they're on the surface, they seem very together and very organized, but when you really talk to them, a lot of that is due to their anxiety and their fear of needing to do things a certain way or be super organized, otherwise they've failed. So these are things to keep in mind when you see very organized type A professionals, is they may be suffering from anxiety or obsessive compulsive disorder. Obsessive compulsive disorder is characterized by the obsessions, which are these intrusive thoughts or repeated thoughts that just keep happening over and over, even though the person does not want to be thinking about these things. And usually they come with a need to perform certain actions or routines in response to these thoughts. These are the compulsions. So this is like, I need to close that door or my mom's gonna die is a very common one that we hear. And it's just this compulsion of I have to do this or else. OCD is also associated with tics, so stereotypical movements. Anxiety is a huge part of it, and increased risk of suicide, because to live like this is a huge burden, and a lot of people do get to the point where they contemplate ending their life because it is such a burden. So that's why it's very important to get these people treatment. It does appear to have a very strong genetic component, so both identical twins are more likely to be affected by this, whereas non-identical twins do not have as much of a chance of being affected if the other is. The demographic for obsessive compulsive disorder, about 2.3% of the population is affected, so that's quite a bit. That's more than your bipolar disorder. Typically, the onset is in the early 20s or early 30s. Males and females are both affected by OCD equally. The symptoms of this include obsessions, so intrusive thoughts. And this is really sad. This is something I deal with my patients a lot, where they feel very guilty about these intrusive thoughts because they are completely out of character. Like, these people are very kind, sweet, and then they're having these thoughts of like, well, what if I just kicked that baby? Or like, what if I just... And over and over they're having these thoughts, and they're so guilty and so sad because they're like, wow, I'm really not like this. Like, I can't believe that I'm having these thoughts. A lot of them self-critical thoughts. A lot of intrusive thoughts of they should hurt themselves, or just bizarre things, like things that they normally wouldn't think and don't even make a lot of sense. One of my OCD patients, who is very, very on the higher end of the scale of suffering from these symptoms, had a very irrational fear that he was possessed, and when you were talking to him, just very often he needed to be reminded that he was not possessed. Fears of germs is the one everyone thinks of, but I actually don't see that as commonly as other irrational fears. Impending doom, feeling that something bad is going to happen if you don't do certain things, very characteristic of OCD. So the compulsions, like we were talking about, just needing to do something to make sure that it's like your anxiety tells you if you do this, you can control the situation. So if you wash your hands 4 times, you won't get COVID. Which really you should wash your hands to not get COVID. There's actually very interesting, if you look at the forums for obsessive compulsive disorder, like the online support groups, people are struggling because they're like, oh, all these years I've had all this anxiety about catching diseases, and like now it's all being confirmed with COVID. So they are having a very rough time with this, and I do very much feel for them. Hand washing, checking, stereotypical movements, repeating actions a certain quantity of times. These are things that people convince themselves they need to do to protect themselves or others, or just a general sense of, if I don't do it, I will be punished for it. Treatment for OCD, CBT is an option, trying to break that relationship between the thoughts and the actions and the anxiety associated with them. Antidepressants, there are specifics that work very well for this. Zoloft, Paxil, Luvox, these are your first-line medications for this. Clomipramine, a tricyclic antidepressant, is used for this. It's second line because it has more side effects, but it is just as effective. Antipsychotics, these are used in treatment-resistant cases and can be very effective in addition to your SSRI or your TCA. So something I wanted to include here, psychotic symptoms, these are important to understand as a component of multiple conditions, not just restricted to schizophrenia. So psychotic symptoms include hallucinations, seeing or hearing things that other people aren't seeing or hearing, even smelling or feeling as though someone's touching you, feeling disoriented, confused, periods of aggression that are out of character for the person. Delusions or paranoia, persecutory delusions are common. So people feeling as though someone is going to come and hurt them or someone is after them is very common with psychosis. This can be part of major depressive disorder. So, for example, some people in a very depressive episode hear someone calling out to them, they hear their name being called, or they hear whispering. So it's not, like I said, it's not just schizophrenia, it can be other diagnoses as well. Bipolar disorder, we talked about how in manic episodes people can have psychotic symptoms. Schizoaffective disorder, this is where you have symptoms that are traditionally thought of to be schizophrenia. However, you also have a mood component, there's a depression, anxiety, bipolar component related to that. Schizophrenia is when it's primarily just the delusions, the psychosis, the hallucinations, and not so much a mood component, not so much depression or bipolar tendencies. Psychotic symptoms can also happen outside of any diagnosis, just being related to withdrawal symptoms. So when people go through DTs or even just really bad withdrawals, they can see and hear things like music playing that's not playing is a very common one that I hear. So I'm going to talk about these briefly, but less so than the other ones because they're less common typically in the working world because these can be significant impairments. Schizoaffective disorder, like we talked about, schizophrenia, symptoms with a mood disorder. This is where your Depakote, your mood stabilizers, lithium would be very helpful. Schizophrenia is more just the abnormal thought process. Paranoid schizophrenia is very much like someone's implanted a chip in my brain, or someone's coming after me, or, I hear voices that are telling me they're going to hurt me and I believe them. Catatonic schizophrenia is more when people are very withdrawn, flat, they're slow to speak or maybe not speaking at all, thought blocking where they go to talk but they just can't get the words out, decreased responsiveness, so when you talk to them it takes them a while to react. The treatment for psychotic symptoms, antipsychotic medications, we're going to first talk about the oral medications and then we'll talk about the injections. So the oral medications, Haldol, Prolixin, Trilofan, this is actually the same chart from bipolar disorder. Usually what we do is the same medications, but typically in higher doses. Your atypicals, Seroquel, Zyprexa, and Risperdal, and we talked about the pros and cons of both of these. In addition to these, you can also use a mood stabilizer like your lithium, Depakote, Tegretol, and those will really be helpful for preventing the mood swings. Long-acting injectables, always beneficial, Invega Sustenna, Risperdal Consta, Abilify Maintaina, Haldol Decanoate, Prolixin Decanoate, Zyprexa Relpreve. These are all great because you can get a once-a-month injection and not have to worry about it. These also do work for bipolar disorder as well. So substance abuse and addiction is a huge part of what I wanted to talk about with high-functioning professionals because it is very, very easy to fall into this when you are in a field where going out for drinks or, just cocktail hour, things like that are very prevalent, especially if you have an addictive personality. So let's talk about alcohol and the different components of addiction. So there's the alcohol abuse component, which is when you're just binge drinking, when you don't drink every day and you don't have a physiological dependence, but when you do drink, there's like no off button. Like, I think everyone knows someone like this. When they start drinking, they just don't seem to be able to stop, but otherwise they're pretty high functioning. That's still important to recognize as an addiction, as an abnormal behavior, because it's really not what you want to have happen. Alcohol dependence, this is when you drink so much that you have a physiological dependence that you need to keep drinking alcohol to prevent yourself from going into withdrawals. Alcohol tolerance, this is where you need more and more drinks to have the same effect as just 1 or 2 drinks used to have for you. And this occurs with repeated use. So the addiction component is really the psychological component, because that's where you have cravings for it, where, seeing a TV commercial about beer makes you crave it, that sort of thing. It's really a psychological problem, which is where therapy comes in to kind of help break that unhealthy relationship. So the epidemiology of alcohol addiction is very interesting. 5.6% of the population, which is quite a lot of people, 14.1 million adults. The greater portion of that is men, though women are affected by this as well. There are estimated 95,000 alcohol-related deaths each year. And in 2014, they recorded 9,967 fatalities related to alcohol-impaired driving, so your DUI type situations, and that does claim a lot of lives each year. Alcohol addiction is like all the other conditions in that it has its environmental and genetic component. So parent or sibling with alcohol abuse issues means that you have an increased risk 3 to 4 times more than the average person. However, when you look at it in the grand scheme of things, only a minority of people related to somebody with alcohol use disorder actually go on to develop alcoholism, which is good. So you have an increased risk, but you're not necessarily, like people think, oh, you're doomed to the same fate. Not necessarily. You just have to be aware of that higher risk. Environmental factors are a huge part of this, because culturally, like a lot of cultures do drink a lot. Specifically when I went to Spain, I realized how much just having a beer with every meal was like very normal compared to here. It was actually very difficult to just get water because it was like often sometimes cheaper just to get a beer. Behavioral influences, if your family does things a certain way, you can learn that behavior if they always have a beer with dinner. It's weird for you not to have a beer with dinner. And the availability of alcohol in your situation, the cost, like I talked about, or the social acceptance. These are things that can predispose somebody to having a relationship with alcohol that's unhealthy. So when somebody has been drinking alcohol for a long period of time, they're going to need to detox. So a lot of people do come into our facility saying, hey, I need to detox off alcohol. I've been drinking too long, too much, and I'm scared to do it at home, which is good because there's some serious risks with doing it at home. It is better to do it in a medical setting. So with detox, what we usually do is use benzodiazepine medications. These work on the same receptors as alcohol, so this is something that can kind of take its place during the detox phase, and it's very easy to control reducing amounts. So it prevents withdrawal symptoms, it prevents your chance of getting DTs, which we're going to talk about in a second, and your risk of withdrawal seizures. Primarily, we use Ativan or Librium, at least at Park Royal. Ativan is good for quick-acting relief, and it does have a shorter period of action, so you can continue to assess those withdrawal symptoms, because since it works so short, you can keep seeing, where the person is at in their detox. Librium is good because it has a slower onset of action, but a longer overall action, so it will keep them from experiencing withdrawal symptoms longer. The bad part about Librium is it's very hard to tell what phase of detox they're in, like how severe their detox is, because it kind of masks it. So DTs is rapid onset of confusion. It's when somebody is going through withdrawal and they just get very, very confused as to where they are, how they got there. They are looking for people that aren't present. They're talking to people that aren't present. This is usually seen around 3 days into withdrawal. It's not right away. It's when your body is starting to realize it's not going to get any more alcohol, and it's trying to cope with that. This lasts 2 to 3 days, so it's very important to be in a safe place when this happens. Like medically, you can die of DTs, so I would recommend, if you ever know anybody who's going through DTs, that you get them to a medical facility immediately. This is seen in 5 to 20% of alcohol detox patients. Symptoms include confusion, hallucination, abnormalities in temperature, so really high temperature, seizures, shaking, shivering, irregular heart rate, and sweating. And like I said, this can get to the point where it's life-threatening. It's mainly, when you see this, it's mainly because of alcohol withdrawal. However, there is a similar type syndrome that occurs with benzodiazepine dependence and barbiturate withdrawal. DT should be distinguished from alcohol hallucinosis. So that's when you have hallucinations, like we talked about, the voices whispering your name, things like that when you're detoxing. But this is not full DTs. This is not something that carries a significant mortality rate. Withdrawal seizures are another serious thing to be concerned about, because this can happen like when somebody's driving or when somebody's, operating something like heavy machinery. It's very important to not go through withdrawal when you are vulnerable. And even just standing around, you can fall and hit your head when you have a seizure. You can bite your tongue, all kinds of things. So you do want to prevent this by going in for treatment. It can occur 48 hours after alcohol cessation. So similar to DTs, not right away when your body realizes it's not going to get any more alcohol. It can be generalized tonic-clonic seizures, or it can be brief episodes of multiple seizures. Prevention of this is with benzodiazepines, so you can do a scheduled taper to make sure that you are covered throughout the duration of your detox. Anticonvulsants can also be added. We kind of look at the risk of somebody having seizures. So like if they have a history of traumatic brain injury, or they have prior withdrawal seizures, or sometimes if they've just been drinking for like 40 years and we just have no idea what withdrawal would be like for them, the scheduled can be safer. So here's an example of a schedule. So on day 1, you can have, 3 milligrams total, drop it down to 2 milligrams total, then 1.5, then 1, and then 0.5, just to kind of gradually give that person a soft landing from their withdrawal symptoms. The PRN is when you do not give it as a schedule, but you basically do an assessment using the CIWA scoring tool, and based on how they score what symptoms they're having, determines whether or not they need an Ativan or whether or not they can skip to the next scoring. So treatment options for like long-term cessation, Campril is a very good one. It antagonizes the actions of glutamate, so it kind of reduces that NDMA activity at the onset of alcohol withdrawal. So then it stabilizes brain chemistry that's altered due to alcohol abuse and alcohol dependence. It prevents cravings in the long run. Naltrexone, this is a competitive antagonist for opioid receptors, so it occupies those receptors before the endorphins that alcohol use releases can get to them. So when you're drinking alcohol, it doesn't have that same, endorphin-inducing, happiness-inducing effect. It's not turned into dopamine, so it does not affect the reward pathway the way it usually would. So think of this as a medication you take to kind of block the enjoyment component of alcohol. Antabuse is a very serious medication because it can have very serious medical outcomes. When you drink alcohol, there's a byproduct, acetaldehyde, that is what builds up to give you a hangover. It's the thing that makes you feel less great when you've been drinking, dehydrated. And so this prevents it from being eliminated. It allows it to build up, so it makes drinking very displeasurable. The problem is some people will drink on top of this and have very serious health effects with it. So opioid addiction is a very important topic to cover here. I'm sure everyone's heard of the opioid epidemic. A lot of times with opioid abuse, people think of heroin and fentanyl. They think of people who they perceive as like lower class or undereducated, but actually opioid abuse and addiction are very, very common in just about everyone because of the often introduction of them in prescription settings. So someone has back surgery, dental surgery, whatever kind of procedure, and they're given opioids, and something in their genetic makeup makes them start to have cravings and makes them want more and more. So often a common story we hear is, I had this surgery, I was on these opioids, and then I got taken off of them, but I just couldn't stop them. So then I looked for more and I turned to the street, and that's how I ended up on heroin and fentanyl. So it's really important for me to mention this in the context of like high functioning professionals, because from my job, from my experience, I do see a lot of people you would not expect to have opioid addiction come in needing withdrawal treatment and detox. So this may not affect you personally, but it's something you can recognize in your loved ones and your friends and your colleagues, and kind of direct them to the correct help. In 2016, an estimated 33,000 deaths occurred to opioid use, and 20,000 of those were from prescription opioids. So again, the majority of this is stuff that's prescribed. 13,000 were due to heroin overdose or fentanyl overdose, so your illicit drugs, but that's really not even as bad as the prescription component. Drug overdoses are now the leading cause of death in the United States for adults under the age of 50, and opioids account for greater than half of those deaths. So similar to everything else we've discussed, it does have a combined genetic and environmental component. This doesn't have as clear a pattern of inheritance. We don't really know the exact statistics on this, so this is an area where more research would be really beneficial. Similar to alcohol abuse, there's your dependence, your physiological need for it, which is where when you stop it, you have chills, hot flashes, sweats, tremors. Runny nose is very common for opioid withdrawal, headache, body aches, anxiety, and irritability. Tolerance, similar to alcohol, requiring more and more to get the effect that you used to get with a smaller amount. Addiction, so the cravings are extremely intense. I don't think, like myself and people who have not been through this cannot understand, but from what patients describe to me, their cravings are so strong. They have them like while they're dreaming, while they're sleeping. They hear a song that reminds them of using. They see a needle and it reminds them of using, like having their blood drawn in a routine setting. Certain people, certain situations. It's a very much like your brain learns to associate things with this reward, these endorphins, this positive euphoric feeling, and it's very hard to break that relationship. So from the medication standpoint of things, naltrexone is going to help reduce that euphoric effect. It's going to block that effect by competing for those receptors, similar to the way it does with alcohol addiction. It's going to make sure that when you use it, you don't enjoy it enough to want to continue using it. Naltrexone is not safe for use in pregnancy, so do not prescribe this or let your pregnant friends use this. Subutex is a partial opioid agonist, so it sort of fills that role, but not as strongly as the opioid did. And so it lets you go about your daily life with like less sedation, less impairment, and less of a dependency on it. So this is really, not the first line option. We'd rather have patients on nothing at all. But if they cannot get off opioids, Subutex is a safer way to maintain them on opioids long term. Subutex alone is safe in pregnancy. However, the combined form Suboxone is not. Suboxone is Subutex with naltrexone. This is used together to prevent the amount of tampering, misuse, so IV use of it, and diversion, the sale of it for abuse purposes. It's still not perfect, but it does reduce that risk. So lastly, methadone. This is a full opioid agonist, so this is a bit more intense, a bit stronger than your Subutex. It still suppresses opioid cravings, but it's a little riskier. It's a little more risk of overdose, a little more risk of health problems because of how strong it is. This can only be dispensed at specific methadone credentialed facilities, whereas Subutex you can get from any outpatient practice as long as the provider is credentialed with a Subutex license. And methadone is safe in pregnancy. Sedative addiction is very, very, very common. I see this a lot. A lot of people who got prescribed Xanax or Ativan or Librium or something years ago, and now they want to come off it and they just can't. And this is why it's good to never start it and to have that knowledge so you don't start it if you're offered. These medications can cause a dependence to the point where you need them, but also a tolerance where they're not even working for you, but also you need them. So you can see how that would be not ideal as a treatment for anxiety. So the treatment to get off of these is similar to alcohol, where we do a taper of benzos. We use the Ativan or the Librium protocol. Benzodiazepine withdrawal can have a DT-like syndrome, and it can include withdrawal seizures, so you do want to do that in a medical setting. Abuse of stimulants, cocaine, Adderall, methamphetamine. We do really symptomatic treatment. There's no protocol that we necessarily will initiate for every single stimulant abuse, but we kind of keep an eye on the blood pressure. Clonidine is something we use a lot for that anxiety, irritability, and hypertension that's associated with the withdrawal of stimulants. And stimulant addiction is something very common, and again, that high functioning, sales, marketing, social situations, like a lot of people have confided in me that in their business it's very common to use these things. The consequence can be pretty severe. The addiction can become very much psychological, and it can be very hard to break these habits with long-term health consequences. So it's something to be mindful of. It is very much something that has kind of made its way into the business world. So treatment for these sedatives and stimulants, there's no long-term maintenance medications like we talked about with alcohol or opioid use. So really what you want to do is get through that withdrawal period in a safe way in a medical setting. You want to do therapy, cognitive behavioral therapy, to kind of break that psychological, emotional desire for it, and then treat the underlying issue. So often these are things used because the person has high levels of anxiety, or they're depressed, or they're not sleeping well, or sleeping too much. You want to address these problems head on so that you're not self-medicating. Long-term programs are always recommended, a 28-day program, and long-term support with a sponsor in substance abuse meetings. We see a lot greater rates of success when you have that kind of commitment. But like I said, there are no maintenance medications for this. Lastly, I'd like to cover self-care. This is extremely important in demanding roles. This is something that I think a lot of us who work very hard are very bad at, because a lot of our good work comes from us being very giving and very good at pushing ourselves. So it's important to take a step back and make sure you're doing your self-care. So what's the main reason for doing self-care? Honestly, you'll be better at everything, really. You can't expect yourself to be your best self and give your best efforts when you're exhausted and you're burnt out. So my favorite saying is, you can't pour from an empty cup. It's really true. You can't give if you're not recharging, if you're not caring for yourself. I like this little picture: do not give your dog cocktails or mocktails. So a good way to do this is just kind of when you're feeling like something's not right, to kind of stop and do like a self-diagnostic, like an analysis, like what is wrong with me? Maybe you need a break. A lot of times people want to push through lunch and push through their break and just work all day because like, oh, I'll be more productive. But actually, no, like when you burn out, you get gradually less and less productive. And there are a lot of studies supporting this, that the more you are working consistently without breaks, the less efficient your work is. So to plan in your breaks, to schedule in breaks, may actually make you more effective and make you use your time better. So definitely start thinking about, how can I take more breaks and be more well rested? Figuring out if you're tired, you can have a cup of coffee. Again, that's like a Band-Aid. You want to really think about your sleep schedule and like, can I commit to being asleep from 11 to 6 or 11:30 to 6:30, or just something where you can get yourself more well rested, because irritability, anxiety, migraines, all these things are found to have a relationship with poor sleep. So I cannot stress enough, it is really important to sleep. Making sure you're eating well, like good nutrition. People report that they are feeling better when they eat better, and that when you eat a lot of junk food and caffeine, that negatively impacts your mood. So do make sure that you're eating well. I think that's really hard when you're very busy as a professional, when you're constantly on the go and you're just doing takeout and this and that. So just kind of try and figure out, maybe a healthy takeout, maybe some fast meals at home that are healthy, just to kind of get yourself feeling more stable. This is probably the most important on this page. Make time for hobbies or things to look forward to. If you have nothing to look forward to, I promise you your productivity will be terrible, because you're just like, oh my gosh, every day like this, and just one thing after the other with no light at the end of the tunnel. So you really want to have something like, oh, every day when I get home, I have 30 minutes of my favorite book. I have 20 minutes of my favorite show. Just whatever it is that you can give yourself to look forward to, both daily, like on a short-term basis, and on a long-term basis. So scheduling a trip or scheduling a staycation, or just figuring out something that like, oh, when I get to the end of this month, I will get myself this, or I will do this. Just something to make you feel like there is something to look forward to, because work is not, like, even if you love your job, work is not the thing you're looking forward to. It's your home life and your personal life. Gratitude. So this is a very important topic and a very tricky topic, because it is a matter of moderation and getting a right balance. You do want to have some gratitude to put situations in perspective, to realize, things are maybe not as bad as you feel like they are. Positive affirmations, acknowledging your accomplishments, like focusing on like how far you've gotten. Because I think very type A, like high functioning professionals will be very hard on themselves And while that does kind of motivate us to keep working very hard, it can wear you down, and that you don't stop to appreciate, like, wow, look at everything that, I've done so far. So it is very important to acknowledge your accomplishments, focus on the positives of the day, because every day is made of positives and negatives. And if you keep consistently focusing on the negatives, you're going to start feeling like you have a worse outlook on life. Whereas if you manually force yourself to look at the positives, you start to feel more optimistic about life. And that can even become a habit you reinforce over time. It's like just being more optimistic and focusing on the good in the world. That'll kind of affect your mood positively at the end of the day. However, and this is very important, you want to avoid what's being referred to now as toxic positivity. This is when it's kind of expected of you to be happy regardless of anything that's going on. And anytime you show any weakness in that happiness, anytime you show any break, it's like, well, others have it worse. You have so much to be grateful for. Just kind of like preventing people from experiencing their own stress. You should be allowed to acknowledge your stress. You should be allowed to admit that you're having a bad day. But there's a line. You just want to find that line. You don't want to force yourself to be overly positive all the time, because that's not healthy. But you do want to have gratitude and realize things could be worse. So, that's a very hard balance to find. It takes time, it takes effort. But once you do find it, it will impact your mood positively. The last component of self-care I'd like to cover is just relationships. When you are working very hard, it is a strain on your relationships. You can often take out your stress on others. Very commonly, people take out their stress on their colleagues. They snap at them, or they're sarcastic with them, or they ignore them. It can cause a trickle-down effect where the whole office is just in a bad mood because, say, the doctor snapped at the PA, and then the PA snapped at the MA, and then the MA snapped at everyone else. And it can just make a room very tense very quick. So it is normal to have days where you're irritable, but you have to learn to channel that in a way that it doesn't affect your colleagues. In addition to making your office unpleasant, another consequence of that is a higher turnover, where people are constantly leaving and you're constantly spending money on retraining people. So, obviously nobody wants that. A way to reduce the risk of this is when you're frustrated with somebody, which is normal when you work with somebody that much, you're going to be frustrated with them at some point. Just cool down, like take a walk, take a moment, step out of the room, go to the bathroom, splash some water in your face. Give yourself some time to work through that emotion and realize that the first impulse you had may not have been the best impulse. And also just focusing on effective, which is productive communication. So snapping at someone isn't really effective. It doesn't really teach them very much other than to be afraid of you. So telling them, hey, I need you to not do this because when you do, it causes problems. Is that understood? Is there something I can help with? Just kind of using the negative event as a teaching tool to prevent this from happening in the future. So another common effect this can have, being stressed and taking it out on others, is damaging the relationship with your loved ones. It's very easy to take things out on your loved ones because you know that usually they'll always be there for you and they'll always forgive you. So that saying of like, you only hurt the ones you love, it's really that when you're close to somebody, you feel more comfortable, like you hold it in all day, you're trying to be professional all day, and then you get home and you're just like, rah. And that's normal, but like it's something you have to focus on addressing because it can be very detrimental to the relationship long term. Like if you're continuously snapping at someone, it's gradually wearing them down, whether you realize it or not, whether they admit it or not. And that's where you get to the point that the relationship one day just isn't salvageable and you two have hurt each other too much to continue. So you really want to avoid doing that. And this is not just a spouse. This can be a parent, a sibling, a friend. So just be very careful. If you realize you're doing this, it doesn't make you a bad person. It just means you've got something you need to work on. To reduce the risk of this, something I like to use is decompression time, which is when you know that you're wound up, that you've had a rough day, and you know that you're not in the mood to talk to people, to isolate, to give yourself a moment to decompress, to find a calm, happy space and just let out a big sigh and, untie your hair and unbutton your pants and just relax. And this is really helpful. A lot of people say, oh, when I get home, it's understood. Me and my wife, we don't talk to each other for the first 30 minutes when I get home because I need to just unwind. And that is a very healthy way to do things if both parties are on board. Acknowledging irritability. For me, I'll just admit that personally, one of the things that's really helped me is knowing that I'm in a bad mood and just vocalizing that, just being like, hey, I'm not in a good mood, and it's not you, but please leave me alone. And that's honestly like better than the alternative. It's better than snapping at someone, just being like, hey, I just need a moment. I'm like not in a good mood. I'm cranky today. I'm hungry, cranky. I didn't sleep well. If you're saying this like every day, you probably need to take a look at that. But every now and then, it's very much like just a part of life to be frustrated some days. Recognizing patterns. So and this is something really interesting, is people have different triggers. So one thing I hear a lot from patients and peers and just everyone is like, I get very stressed when, and it's something that's very specific to them. So I'm thinking of a patient that was like, I get really irritable when I'm getting ready to leave the house. Like in that period between like getting dressed and getting out the door, like I get super irate if anybody talks to me. So just being self-reflective enough to think about the patterns of like, I get irritable when blank. And once you recognize that, it's easier to control that, or at least warn others about it, or eliminate it entirely. So just be mindful of your triggers and what makes you feel irritable. So thank you so much for listening. If you got this far, I really appreciate it. I use mostly the current psychiatry. I also used the addiction websites for opioid and alcohol. So I hope this was helpful for somebody. These are not necessarily just to treat your own conditions, but to recognize them in your loved ones and know that there are options available and refer them to the right kind of treatment.